I need some help in here. What's going on? Respiratory distress. Sats are dropping 87%. Lung injury from the fire?
Inhalational lung injury is a major concern if the saturation is dropping, especially if the patient was burned in an enclosed space and there are signs like soot in the oropharynx and singed nasal hairs like this case. Smoke inhalation causes direct thermal injury to upper airways, causing inflammation, edema, and bronchospasm, all of which result in acute respiratory distress syndrome. This typically results in non-cardiogenic pulmonary edema, which can cause hypoxia. Another thing is sometimes aggressive fluid resuscitation can overshoot, leading to pulmonary edema. It could also be due to developing pneumonia, as burn patients are susceptible to infections.
It's not just the low sats. Events showing high peak pressure, low tidal volume.
Restrictive pattern means low lung compliance, which means lungs are stiff and hard to inflate, hence restricting the work of breathing. This can lead to low oxygen saturation and hypoxia. This pattern is typically seen in pulmonary fibrosis, but can also be seen in ARDS due to inhalational injury, where the lungs are edematous and hence can be stiff or non-compliant. More convincing explanation relevant to this case would be that since there are extensive burns all over the body, including chest wall, massive chest wall burns, especially full thickness, circumferential burns all around the chest, can restrict expansion and lead to restrictive pattern. Eschar formation is the characteristic feature here, which means the burnt skin becomes tight and leathery, which is called eschar. This eschar is non-elastic and does not stretch with inspiration. It is especially dangerous when it forms a circumferential band around the chest and essentially restricts the lung from expanding during inspiration. On ventilator, this is seen as high peak pressures and low tidal volumes, meaning the amount of air inspired and expired decreases, along with high plateau pressures and poor oxygenation and saturation, despite the ventilator providing air with FiO2 100%.
Restrictive pattern? Most likely. I'll grab Robbie and Langdon.
Wait, what's that? What's going on?
Ventilator is having trouble pumping air into Teddy's lungs. Burnt skin loses elasticity, now his chest wall's too tight.
Well, what can you do?
So, the emergency management here would be escharotomy, which means to make an incision through the eschar down to the subcutaneous fat. This is done at the bedside like here or in the OR. It restores chest wall compliance since the eschar is no longer holding the chest wall firmly as a band. This allows the lungs to expand during inspiration.
We're gonna have to cut the burnt skin, release pressure on the chest wall, help Teddy breathe.
So after you cut his eye, see you again?
This will give us our best shot at preserving his vision, yes.
A lateral canthotomy releases pressure from the orbit due to the retroorbital hematoma. It doesn't improve vision immediately. It prevents further ischemic damage to retina and optic nerve by releasing the pressure over the arteries that supply it. The procedure could reverse ischemic damage if blood supply is restored. But if more than 90 minutes has passed, necrosis sets in and damage is irreversible. Also, the vision loss here has likely more complicating factors like blood in the anterior chamber or hyphema, which will take time to resolve.
Dr. McKay, are you ready to do the honors?
Who, me?
We are a teaching hospital. Are you still here to learn?
Yes. Yeah.
Okay. You can release that hemostat now.
A hemostat is a surgical instrument used to control bleeding by clamping blood vessels, the one which she is holding right now.
There were scissors.
The length of the crushed area is going to be your guide for the length of your cut.
The procedure here involves a lateral canthotomy, which means cutting the outer corner of the eye, followed by cantholysis, which means cutting the lateral canthal tendon to decompress the orbit. When the lateral canthal area is crushed due to trauma, it's often swollen, firm, and discolored over a specific length. That crushed segment correlates to the zone of increased pressure from bleeding or swelling. Therefore, the incision length during canthotomy should match or slightly exceed the extent of the crushed zone to ensure that we've relieved enough pressure. Normally, you make about a 1 to 2 centimeters horizontal incision at the lateral canthus. But if the trauma has visibly crushed a longer segment, we may need to extend our cut to fully access the lateral canthal tendon. The lateral canthal tendon has 2 limbs. The superior crus is attached to the upper eyelid and the inferior crus is attached to the lower eyelid. The inferior crus is tighter and contributes more to orbital compartment pressure. It is the most important structure to be cut, as cutting it allows the globe to move forward, relieving pressure on the optic nerve and retinal vessels.
Good.
Do the forceps?
lateral canthotomy is done, but cantholysis, meaning cutting the superior and inferior cruri of the lateral canthal tendon, is still left. As said earlier, inferior canthal tendon is the most important structure to be cut.
Feeling for the inferior and superior crus.
How can you see with all that blood?
You can't. It's all tactile. Feels like two guitar strings.
Too much blood to see anything. We use scissors to dissect down to find and cut the inferior crus of the tendon. If pressure is not adequately relieved, we may then proceed to cut the superior crus as well.
Medicine bomb. Inferior
Yeah.
and superior.
Nice. Good.
So, canthotomy and cantholysis have been done. There is immediate relief from the orbital pressure and the intraocular pressure should drop.
Well, that's a lot of blood.
Okay, let's get a repeat pressure.
It's getting a lot brighter.
Pressure of 18?
As we said, normal intraocular pressure ranges from 10 to 21. 18 is normal. The procedure has been successful.
Perfect. CT can take him as soon as we dress the wound.
Let's page ophthalmology and tell him to prep for surgery.
The CT scan of the orbit would identify the source of pressure, that is the hematoma and its extent, rule out possible fractures or other globe injuries, and guide further treatment. If there is a large retrobulbar hematoma, it may need to be surgically drained and evacuated in the OR by ophthalmology team. If orbital fractures are present and unstable, they may require surgical repair as well. Also, the patient has hyphema, which is grade 4, so that might require surgery to drain the blood as well.
Doc, thank you. Thank
My
you.
pleasure, my pleasure. Good luck to you, Everett.
Hey, thanks for letting me do that.
You sound surprised.
Yeah, I figured after the whole Teresa thing, you might bench me.
A pissed off attending won't provide you chances for procedures as often. It depends on the mood, and this happens mostly in surgery where you'd be allowed to do so much more than just sutures and dressing if you are in good terms with the attending surgeon.
Am I still pissed that you went behind my back? Absolutely. And if you ever do it again, you can bet your ass that I will bench you. But this is a teaching hospital, and teachers can still learn stuff. I saw a sad, confused boy, and that's all I thought about. I did not think enough about those girls.
Dr. Robbie is a humble and down-to-earth attending. Admitting that you were wrong or you don't know is the first step to learn anything new, and it comes handy in all fields, including medicine.
Any word on Dana?
She should be coming back from CT soon.
Burn victim's tanking. We need you.
Oh my God, I can't wait for this shift to be over. This procedure is called an escharotomy. We need to cut the skin so that the chest wall can expand.
We learned before that the burn patient has extensive burns on his chest wall, front and back full thickness, burns where the dead burnt skin becomes leathery and tight, called as eschar, which is rigid, not elastic, and if this forms over the entire circumference of the chest wall, it does not allow chest wall to stretch with inspiration, hence not allowing lungs to fully expand, causing restrictive pattern of lung disease and impairing normal ventilation. Escharotomy is a life-saving surgical procedure used to relieve pressure caused by circumferential full-thickness burns that restrict breathing in the chest wall. It could also be a limb-saving procedure when there are such burns with eschar acting as a rigid circumferential band to compromise blood flow in the limb by compressing the limb's blood vessels. In escharotomy, we make an incision through the eschar down to the subcutaneous fat. This is done at the bedside like here or in the OR. It restores chest wall compliance since the eschar is no longer holding the chest wall firmly as a band. This allows the lungs to expand during inspiration.
That sounds painful.
Whitaker?
He's still heavily sedated. He won't feel a thing.
We gotta prepare for sterile field, provide local anesthesia. Here the patient is already sedated from the procedural anesthesia provided for intubation, so there's no need. Then we mark anatomical landmarks to avoid nerves and major vessels. We then use a scalpel or electrocautery to make full thickness skin cuts through the eschar down the subcutaneous fat, but not into muscle. The incisions given are vertical, midclavicular, and horizontal. Clavicular incisions are given bilaterally from clavicle to the costal margin vertically along the anterior axillary line, avoiding nipple line in males and breast tissue in females. Then, a horizontal incision is given that connects those two vertical incisions. This helps to relieve circumferential thoracic pressure and restore chest wall movement for ventilation. The bleeding in this procedure is minimal as eschar is avascular.
This is gonna help Teddy breathe. Sat's 83, peak pressure's 40, tidal volume's Only
There's high peak pressure and low tidal volume, essentially suggesting restrictive pattern. Normal tidal volume is around 500 milliliters. That's the amount of air that gets in and out. Here it's only 300 due to restriction of chest wall and poor lung expansion.
300.
I want you to watch Dr. Langdon as he makes this vertical incision. Then you're going to do the exact same thing on your side and follow his instructions.
I'm sorry, I don't think I can watch it.
Jordan, would you start at lateral clavicle?
So, they're going to give the clavicular incisions bilaterally from lateral end of clavicle to the costal margin along the anterior axillary line.
Down, anterior axillary, and lower rib margin.
The tissue's really popping out.
Which illustrates what?
It indicates the release of pressure that built up beneath the eschar due to the eschar's rigid and constricting nature.
The pressure underneath.
Your turn.
Here goes.
A little more pressure. Yeah. You make a decisive incision and get through the eschar. Go back a little deeper on that first section.
As pointed before, the incisions are full thickness skin cuts that have to go through the eschar down till the subcutaneous fat, but not top deep into the muscles, or else the chest wall muscles get compromised, worsening the restrictive lung pattern.
Okay.
Yep, good. Looking good. Okay, now the horizontal incision, Dr. Langdon.
And connecting the two incisions.
They've nailed even the minimal bleeding part in escharotomy, considering the detail that eschar is avascular. This series is way too realistic.
That ought to do it.
Peak pressure's already down to the 30s.
And tidal volume is coming up.
So that's 91.
Escharotomy has already showed dramatic improvements in the patient.
That was wild.
Let's stress these wounds and send off the blood gas.
An arterial blood gas analysis is done after escharotomy to assess the improvement in hypoxia and hypercapnia by checking the partial pressures of oxygen and carbon dioxide.
Well done. And very well taught, Dr. Langdon.
Thank you.
Ooh, Robbie, Dana's CT results are back.
No intracranial hemorrhage, no skull fracture, non-displaced nasal fracture, but the rest of the facial bones look intact.
Any hemorrhaging into the sinuses?
Nada. Great.
Since there are no other grave injuries, the non-displaced nasal fracture can be treated conservatively with ice packs applied for 15 to 20 minutes every few hours in the first 48 hours to reduce swelling, along with head elevation and pain meds like paracetamol. We gotta avoid NSAIDs like ibuprofen in the first 48 hours if there's concern for bleeding. We gotta still observe for any worsening deformity, persistent bleeding, nasal obstruction, or development of septal hematoma till few days.
Could really use her back on the floor. What? I'm just saying.
Mind if I give her the good news?
No, go for it. And anything else she needs.
I got it.
About the whole thing with Santos and the seizure patient,
What about it?
I'm sorry for laying into her so hard.
Why do I feel there's a butt coming?
But I don't think she's a team player.
How so?
She's cherry-picking cases. She gave Whitaker a shitty nickname after his patient died this morning. She's even harassing Giovanni to get a rec from her mom for surgery.
The sad part is you will find lots of Santoses in the journey to become a doctor and beyond, just very difficult to deal with. The other issue is we can't avoid people who belittle us in medicine. We have to encounter them every single day or even work together with them, as medicine is a teamwork.
If she wants to be in surgery, what's she doing in the ER?
That's a great question. Why don't you ask her new BFF Garcia? I know that you've seen those two. I'm the only one calling her out, so she has an axe to grind. You've always said that being in the pit is like playing a team sport. A team has to be able to trust each other. If we have one weak link, this whole place goes to shit.
Good meeting.
Again, letting someone go isn't the solution, as it rather hampers the number of patients that can be taken care of by decreasing the workforce. She isn't necessarily a weak link or not smart. She is just oversmart and condescending to her colleagues and disrespectful to her seniors, which do need to be addressed.
Call Zazie and Family Med. They open up their urgent care at 5. Let them know we're sending up the 2 hockey kids.
Yep, Zazie and Fam Med. Okay, copy that.
And please check in on Earl. Poor thing got caught in the crosshairs of that mom fighting. You would bring him another sandwich. No egg salad.
Dana, I got you. Okay, rest up, bud.
I can resonate with this. Even when you're not able to work, you'd still want your workplace to function as it used to when you were working. And it becomes a habit to just be helpful and kind to people over the years. This just naturally comes after decades of providing healthcare as medical staff.
Ugh, can take the girl out of the ER, but you can't take the ER out of the girl.
Old habits die hard.
Let me take a look. Whoa, she's a real beauty, all right. But your CT came back clean. Nothing Mother Nature can't heal on her own.
Meaning the undisplaced nasal fracture would heal by itself without any surgical intervention.
Too bad. Looking for a free nose job.
Probably get hazard pay.
2 for 1.
Hazard pay in medicine is extra compensation given to healthcare workers who are exposed to increased personal risk due to the nature of their work, particularly when working in high-risk environments, treating infectious or dangerous patients, performing procedures with high exposure risk, or facing occupational violence or trauma, like in psychiatry wards or in ER, like this case.
Oh, you know, you're cleared to go back to work if you want. Or home.
Not ready yet. Yeah.
No. Got a lot to think about.
Both are patients at the end of the day. One just had miscarriage, needs adequate rest and hydration. The other also needs rest, ice, and pain meds.
What do you call a group of brains who form a singing group?
What?
A glee club?
Glia are a group of non-neuronal cells in the nervous system that support, protect, and assist neurons. These are astrocytes, oligodendrocytes, microglia, and ependymal cells in the CNS.
Oh, good one.
Keep me posted if there are any changes.
What's with Dr. Mehta and the jokes?
You know why they say laughter is the best medicine? Because it's true. Laughter releases endorphins. Endorphins help relieve pain.
Endorphins are natural pain-relieving chemicals produced by your body, specifically by the central nervous system and pituitary gland. Endorphins basically mean endogenous morphine, which bind to opioid receptors in the brain and reduce pain perception, induce feelings of pleasure or euphoria, help with stress relief, and also modulate appetite, sleep, and immune response. These are released in response to painful activities like exercise or injury, or in pleasurable activities like sex, eating your favorite food, listening to music, or even laughter.
So what?
Dr. Mehta thinks that if a joke helps raise spirits and makes people feel better, then he's all for it. It's his special sauce.
Neurologists often deal with diseases with poor prognosis like stroke, so laughter is just a coping mechanism to relieve the inner stress and weighing nature that comes with the job.
Do you have a special sauce?
I'm pretty data-driven, but I really like to talk to my patients about their lives. Makes them feel important.
Empathy in patient communication and making them feel heard and seen goes a long way in all fields of medicine.
She's waking up.
How are you feeling?
Okay. Are you trying to say okay?
Yes, the thrombolytics are working.
Her aphasia, both receptive and expressive, has resolved. She can comprehend the question that was being asked and formulate her answer into words. This indicates that the ischemic damage to her language center in the dominant hemisphere was reversible, and hence the lysis of clot in the middle cerebral artery via tenecteplase reversed the ischemia.
Can you lift your right leg for me? That's okay. Try moving it from side to side.
There is slight improvement of her hemiparesis as well.
Can you tell us your name?
Yeah. Oh, maybe you can type it out on the screen. Here. Vera? Okay, what's your last name?
Malahi?
So, she is also well oriented with respect to person at least, which is a big improvement.
Well, hello, Vera Malahi.
Hey. Oh, Chad's a little piece of work. Appreciate you dealing with him. You know, it was actually kind of fun.
I did not have that on my bingo card.
Well, you know, patients under propofol are always a good time.
We've already known that propofol, which is a sedative hypnotic used as an anesthetic agent, can cause disinhibition before full sedation takes place. Going a bit deep into this, propofol is GABA A receptor agonist, meaning it enhances inhibitory neurotransmission in its full effect. But initially, it can suppress cortical inhibitory neurons, especially in the prefrontal cortex. This leads to a temporary imbalance where excitatory behaviors become unchecked, causing disinhibition. This might lead to unfiltered speech, crying, laughing, talking excessively, confessions, or emotional outbursts. As consciousness fades, the filters from the conscious mind go away, leading patients to express whatever they're thinking in their mind without fear of judgment. This occurs until full CNS depression kicks in and excitatory neurons are also suppressed. Interestingly, propofol also causes anterograde amnesia, so what was spoken during that time is not even remembered afterwards by the patient, as no memories were formed.
Yeah. What did you say? Nothing. Nothing to worry about unless you're concerned he still has a thing for you.
Oh, please euthanize me if I ever even consider it.
Euthanasia is the intentional ending of a person's life to relieve suffering, typically from a terminal or incurable condition. It is a highly controversial medical, ethical, legal, and moral issue. It's often considered in terminal cancer, ALS, severe neurodegenerative diseases, or intractable chronic pain or suffering.
But if I could go back, I wouldn't change a thing. Without Chad, I wouldn't have Harrison.
You're very lucky.
I was getting ready to take her up when she developed angioedema and her stats dropped.
A little bit of Strider.
Swollen lips, swollen tongue.
The prominent history here is that she was thrombolized with tenecteplase. Thrombolytic drugs are tissue plasminogen activators, meaning they convert plasminogen into plasmin. The primary function of plasmin is to lyse fibrin clots. However, plasmin can also cleave high molecular weight kininogen into bradykinin. This leads to overproduction of bradykinin. Bradykinin is a vasoactive peptide that dilates blood vessels, increases vascular permeability, and promotes fluid leakage into tissues, hence causing angioedema. Angioedema is basically non-pitting swelling that develops especially in lips, tongue, mouth, and airways. This occurs in 1 to 5% of thrombolyzed patients and tends to appear within hours of infusion. Angioedema may even present as unilateral, affecting only one side, the same side as the infarct, meaning the contralateral side of hemiparesis. Now, the main concern here is the edema of the airways. This can lead to upper airway obstruction, which can present with stridor, a high-pitched, noisy breathing sound heard during inspiration due to air passing through narrowed airways. This can lead to difficulty in breathing and gasping. As less air enters lung due to obstructed airways, there is decreased oxygenation and drop in saturation. Aphasic patients may not be able to communicate symptoms like throat tightness, difficulty breathing, or tongue swelling. Therefore, clinical vigilance is crucial, especially in aphasic or sedated patients.
Vera, this is a side effect of the medication we gave you.
Sats her up with high flow nasal.
It's anaphylaxis, get Robbie?
Angioedema is not always anaphylaxis.
I know, but it can progress to it and cause an obstruction.
If the patient has no rash, no itching, and was recently given TPA and developed tongue or lip swelling, we should always think bradykinin-mediated angioedema. If the patient has rash, itching, hives, and wheezing along with low blood pressure and the reaction is sudden, we should think anaphylaxis. In bradykinin-mediated angioedema, like in this case due to thrombolytics, there is usually no rash, no itching, no hives or urticaria. The swelling develops more gradually. It often affects just the tongue, lips, or face. It may not respond well to epinephrine or antihistamines and can cause life-threatening airway obstruction if it spreads to the pharynx or larynx, causing stridor. Anaphylaxis, on the other hand, is a systemic allergic reaction that happens very quickly within minutes, often after exposure to allergens like foods, drugs, insect stings, latex, and so on. Swelling of the lips or tongue may also be present as histamine-mediated angioedema initially, but is usually accompanied by or progresses to other symptoms later, giving the full picture of anaphylaxis. So, angioedema can be the initial presentation of anaphylaxis, but it's histamine-mediated. Other symptoms include skin rash, hives, or itching, and patients often have shortness of breath and wheezing due to histamine-mediated bronchoconstriction. There's hypotension, hence often called as anaphylactic shock. It responds very well to intramuscular epinephrine, which is the first and most important treatment that reverses the bronchoconstriction. It's an IgE-mediated immune response involving mast cell degranulation and histamine release, hence responds well to antihistamines as well.
If it's just angioedema, I can reverse the swelling fast with IV epi.
The treatment here would include, in general, corticosteroids like methylprednisolone, diphenhydramine, which is an H1 antihistamine, H2 blockers like ranitidine, and epinephrine 0.3 to 0.5 milligrams. Targeted treatment would ideally include bradykinin B2 receptor antagonist like icatibant, which antagonizes the effects of bradykinin. As pointed out just before, since it's bradykinin-mediated angioedema, epinephrine and antihistamines may or may not work as well as in the case of anaphylaxis.
BP is 165/85.
Prep ketamine and rock for intubation.
Wait. Dr. Mohan, you just said...
We're not intubating yet.
But she's gonna arrest.
The patient is to be ideally prepared for intubation since there are already signs of airway obstruction like stridor. It has to be done before the airways get shut due to swelling and before the airway swelling obstructs the visualization of vocal cords for intubation. Otherwise, emergency cricothyrotomy or tracheostomy may be the only option if intubation fails. However, if the meds given like epinephrine can reverse the angioedema and stridor improves, intubation could be avoided or at least delayed.
What happened?
Angioedema with stridor. Respiratory's on their way. We should intubate, right?
Good BP and O2 sats. Epinephrine can reverse the swelling right away.
Epinephrine is a potent vasoconstrictor. It can constrict the dilated blood vessels and reduce the swelling of angioedema and potentially improve airway edema as well, resulting in improvement of stridor.
I pushed 10 mics of IV epi, starting her drip at 5 cc's, 5 mics per minute.
So, we prepare infusion of epinephrine by mixing 1 milligram in 1 liter of normal saline or 5% dextrose. The concentration becomes 1 microgram per milliliter of epinephrine. Now, infusion is started at 1 to 4 micrograms per minute and can be titrated up to 10 micrograms as needed.
Sats are holding at 95 on high flow. BP is good.
The saturation has already improved, so the epinephrine has worked by reducing the airway edema and also causing bronchodilation, so as to improve airflow and oxygen into lungs. This might have avoided the need for intubation.
Vera, we're gonna sedate you so that we can help you breathe better.
Or not. Let's just wait a minute.
How'd you get that epi drip hung so fast?
Bedside drip. I mix 1 milligram with a liter.
Nice.
Are we intubating? Are we not intubating?
Not.
Stridor is improving.
Is it getting easier to breathe?
Stridor has also improved. However, she has to be kept under constant monitoring of heart rate, blood pressure, and ECG since epinephrine drip is given, along with monitoring for worsening of airway edema and saturation despite medications, at which point intubation might be necessary.
Speech is coming back. 50 diphenhydramine, 125 solumedrol.
So, additional supportive meds include corticosteroids like solumedrol or methylprednisolone, 125 milligrams to reduce swelling, diphenhydramine 25 to 50 milligrams, which is an H1 antihistamine, along with H2 blockers like ranitidine 50 or famotidine 20 milligrams.
Do you think Dr. Mehta will want her intubated for the thrombectomy?
Not necessarily. If she can talk and move during the procedure, then they can monitor any changes in the neural exam.
So, the patient here is also a good candidate for mechanical thrombectomy, which can be done as there is DWI flare mismatch on MRI, meaning ischemic tissue is still salvageable and there's likely a large vessel occlusion, likely M1 branch of the left middle cerebral artery, which explains all her symptoms before. Here, the clot blocking this artery is removed via minimally invasive endovascular approach by suctioning it directly or capturing and pulling it out with stent. Now, if the patient is awake, talking, and moving during the procedure, it allows the interventional team to continuously monitor neurological function in real time. For example, if the patient suddenly stops talking, weakens, or loses consciousness, it may indicate new ischemia, vessel reocclusion, hemorrhagic transformation, or embolization of the clot to new territory, and the team can plan the next steps accordingly. Hence, conscious sedation is generally preferred for mechanical thrombectomy over general anesthesia with intubation.
Slow-mo, no-mo. Sorry, I think Dr. Mehta's rubbing off on me.
We're taking him up to our burn unit. He'll be in great hands. They've had lots of experience with cases like Teddy.
Serious burn cases like this one are usually taken care by specialized units that only take care of burn patients, called burn centers or burn units. These units provide comprehensive care, including surgical and nursing wound care, critical care, and rehabilitation to burn patients. They also take care of various types of burns, including thermal, chemical, and electrical.
What now?
We will continue with IV fluids and pain meds. We'll support his breathing with the ventilator, and we'll keep his wounds clean, look for any signs of infection.
Basically, debridement of dead tissue and dressing every single day. Reminds me of the general surgery posting. Dressing of a burn patient takes a very long time and is tiresome.
Then later, the plastic surgeons can do skin grafts.
He's gonna be okay.
It's a teamwork between general surgeons and plastic surgeons. In skin grafts for burns, healthy skin from one part of the body is transferred to cover the burn wound. This is necessary for full thickness burns where the skin's natural healing process is insufficient to cover the wound.
Teddy's condition is very critical, so no promises, but our team's going to do everything they can to give him the best chance possible.
I'll make sure to stop by the ICU, check in on both of you.
I can't begin to thank you enough, Dr. Whitaker.
Student doctor.
Humble med student he is. We used to be called doctors all the time while in med school itself during our postings too. We were going to be doctors soon, so I don't think it makes that big difference to call a student doctor a doctor.
Don't forget about dinner at the farm. And, make sure to brush up on your diaper changing skills.
With 7 nieces and nephews, I'm a diaper genie, so...
This is yet another portrayal of a good patient-doctor relationship in this series.
You know, you just called yourself the trash can, right? Before you grab your next patient, call Kiara, have somebody go upstairs and talk to the wife.
Amy, why?
We wanted to give her hope, but the reality is her husband's not going to make it.
Mortality is extremely high in cases of burns with more than 80% total body surface area, especially with full thickness depth and inhalation injury. Here, it's 90%. If the patient survives the first 48 to 72 hours in the ICU, the attention shifts to infection, septic shock, and multi-organ failure, all of which can also lead to death eventually. Historically, survival is often estimated using the Bauch score. Bauch score means age plus % of TBSA burned. If there's inhalation injury, we add 17 points. A Bauch score of more than 140 is associated with extremely high mortality. Here, Bauch score is 28 plus 90 plus 17, which amounts to 135, which is extremely close. So the patient has grim prognosis. Prolonged hospitalization in ICU is the norm, with electrolyte abnormalities, acute kidney injury due to hypovolemia, and sepsis from burn wounds that get secondarily infected with hospital-acquired resistant organisms like Pseudomonas or MRSA, which eventually leads to death of the burn patient.
He's stable.
His chance of dying in the next week is over 90%.
He's young, he's strong. Maybe he's the 10%.
Maybe, but he's a lot more likely to die of sepsis before his kid is born. Call Kiara.
We gotta counsel the patient's family member about the poor prognosis so that it gives the patient a reality check and what to expect and what not to, so that they could prepare to face the worst in future.
The CT shows a hairline orbital floor fracture.
Trauma to the eye could definitely cause orbital fractures, including orbital floor fractures and even skull base fractures. These are ruled out via CT scan. A hairline fracture means one which is thin and barely visible, undisplaced fracture that can be managed conservatively with meds and rest and would heal on its own.
But thanks to the canthotomy, the hematoma isn't pushing on his eyeball.
The canthotomy releases the pressure exerted by the retroorbital hematoma to the eyeball at the front, decreasing the intraocular pressure and, more importantly, releases pressure exerted to the blood supply of retina and optic nerve, essentially preventing further ischemic damage and permanent blindness.
Will I be able to see?
That's why you need surgery. The ophthalmologist will drain the blood inside the front of your eye and replace it with the clear fluid you need to see.
As said before, if there is a large retrobulbar hematoma, it needs to be surgically drained and evacuated in the OR by ophthalmologist. Here, the orbital fracture is undisplaced and hairline, so doesn't require surgery. The patient also has hyphema, which is grade 4, meaning the entire anterior chamber is filled with blood, so this also could require surgery to drain the blood. Drainage of hyphema, even if grade 4, is generally not considered right away like this. It's considered if intraocular pressure is more than 50 millimeters of mercury for 5 days, more than 35 for more than 7 days, if corneal blood staining is present or imminent, or if patient has sickle cell disease or trait, which increases the risk of optic nerve ischemia at lower pressures. After drainage of hyphema, the aqueous humor is replaced with balanced salt solution.
We're ready for you now.
Hey. Don't worry, bud. All right? So he has the surgery, stays overnight, he goes home tomorrow?
It depends on how the surgery goes and what his post-op results are like.
Give or take.
It could be as soon as tomorrow, yeah.
Okay.
Nobody can really dictate the course of disease and treatment in the hospital. Patients often ask, when will they recover fully? And nobody can really tell the correct answer to that. Everybody is different. The same disease with the same treatment, whether it be surgical or medical, might work for some and might not work at all for others. Also, what happens in surgery is unpredictable. So the question of what will happen in future itself is futile to begin with.
So he could be game ready by Thursday.
Sir, your son is
freaking out because he may never see out of his left eye again.
Yeah,
No, forget baseball. And just be his dad. God, it can't be that hard.
The father definitely seems more excited for his son's baseball game than the son himself.
There's a waiting room up by surgery, 6th floor. Right off the elevator, you can't miss it.
Angioedema responded to epi, diphenhydramine, and steroids.
Excellent.
The edema has completely gone with resolution of lip and tongue swelling in just few minutes. This scene made it seem like the patient never had angioedema at all. The resolution back to normal can't be this dramatically quick in real life, especially if it's bradykinin mediated like this case, where epinephrine doesn't work well. Even in histamine mediated angioedema, initial improvement typically starts within 5 to 10 minutes of epinephrine, and significant reversal often occurs within 30 to 60 minutes, along with other adjunct medications.
Thank you. You're very welcome.
Neurotransmitter makes the best adhesive.
I don't know.
Glutamate. Glutamate. Am I right?
Nicely done, Dr. King.
Glutamate is the primary excitatory neurotransmitter in the brain. Excess of glutamate results in excitotoxicity, which can lead to degeneration of neurons, contributing to dementia in Alzheimer's disease. Hence, NMDA receptor antagonist memantine works by blocking the glutamate receptors.
You know, it was really quick thinking back there. I'm really sorry if it seemed like I doubted you. I just...
Honestly, I surprised myself a bit.
Yeah? Well, you trusted your gut. Yeah, maybe that's your special sauce.
Maybe.
Dr. Mohan, what if I don't have special sauce?
Of course you do. Just be yourself. They'll come.
You don't need to be special to become a good doctor. Just take care of your patients and think for them in the best of their interests, and you will be appreciated by them, which is what brings us fulfillment in what we do.
So, now might be a good time to go over some doctor-patient interaction guidelines.
Sorry, that was just such
so
an
overbearing.
Well,
Sorry. Look, do I think you needed to chill out a little bit? Yes. But he's a parent, and this might be his way of coping with the stress of a very frightening situation.
Not thinking or talking about what makes you stressed and distracting yourself with the good that can occur out of it could be a coping mechanism for stress. Sometimes things happen so fast that we don't even have time to process all that happened, and we tend to underestimate the gravity of the stressful situation. The father probably needs some downtime.
I'm sorry, I don't know what came over me. No, I do. You and that baseball kid are two pressure cooker prodigies in a pod. Just, as physicians, we gotta learn to keep our emotions in check and not let our personal experiences interfere with our professional responsibilities.
This is easier said than done. We'll definitely be biased from our own personal experiences in life. Sometimes we have to stick to just practicing medicine and forget the other aspects of the patient intertwined with the disease we're trying to treat. Again, it's easier said than done.
how long did it take you to learn that?
I'm still learning. And I also learned to never get on your bad side.
Because her mom is a senior surgeon, you don't want to be on the bad side of your desired specialties attending, that's for sure.
So, how's your first day going?
So far, so good.
Getting along with everyone?
Yeah, pretty much.
Except Langdon? So, in this ER, we all need to work together as a single unified entity. And if two people on my team can't work together, it kind of throws the rhythm of the place off.
Understood.
It's the battle of the egos. It's usually seen between colleagues at the same level, not really between residents and interns. As an intern, you'd want to get along with a resident so that you could learn more, unless the resident is too overbearing and toxic, which Dr. Langdon doesn't seem to be. He was reasonably scolding her because she was disrespectful to her colleagues and to him too.
My duty, regardless of personal relationships, is to make sure everybody on my team is doing okay. So, are you doing okay?
It's not a big deal. I can handle it.
If it's a constructive criticism from the senior, you should actually learn from it. If it's just harassment and belittling, you should report it to your attending.
Handle what?
Nothing. It's fine. I don't want to get anyone in trouble.
If it pertains to the healthcare practice, you gotta complain. If it's just interpersonal issues and ego, it's irrelevant and should be sorted out between the two.
Okay, if there's anything that could affect my ER, I need to know about it, and you have a responsibility to tell me.
I guess the whole saga surrounding her investigation into Dr. Langdon regarding lorazepam and Librium is finally going to get a conclusion.
Hey, did they catch the bastard who sucker punched you?
I haven't heard.
Well, when they do, just send them to me. I can make it look like an accident.
Let me just take you up on that.
You betcha.
By the way, it's already episode 10, and we still don't know why the patient is restrained to her wheelchair. What's her history? What disease is she suffering from? What's her update? Nothing is mentioned till now.
You've been paroled.
Are you sure?
Yep.
Oh,
Okay. Yeah, okay.
Yep.
Go check on Martin.
Got a sec?
bless you.
For you, boss, I got two. What's up?
Just a sad reality of disrespect towards healthcare providers. Spending countless hours studying and finally becoming it, still leaving family behind to come to work and doing 24-hour shifts to serve patients, only to get sucker punched by a disgruntled patient. Incidents like this just tear the whole rhythm and flow and enthusiasm we had and make us question our decisions.
I heard there's been some inconsistencies with meds intended for your patients.
What?
Frank, have you been helping yourself to benzos from the ER?
Yeah, I've been stealing blood, too.
I asked you a question.
Wait, are you serious? What are you doing?
Benzodiazepines like diazepam, alprazolam, lorazepam, and Librium or chlordiazepoxide are commonly abused because of their powerful psychoactive effects. Benzodiazepines enhance the effects of GABA, the brain's main inhibitory neurotransmitter. This causes relaxation, drowsiness, sedation, and in some people, a mild euphoric high, especially when taken in large doses or combined with other substances like opioids or alcohol. Some benzos like alprazolam or Xanax act quickly, which reinforces the reward feeling. There is rapid relief from anxiety, stress, or panic, which encourages repeated use, and over time, people get addicted. The body quickly builds tolerance, requiring higher doses for the same effect. Physical dependence can develop in just a few weeks, leading to withdrawal symptoms when stopped. And people often continue use to avoid withdrawal, which presents with anxiety, insomnia, tremors, and in severe cases, seizures if not used.
Really? Santos, whatever the hell she told you is bullshit.
I didn't mention Santos.
Didn't have to. I told you, she is trouble.
Have you ever taken a patient's medication?
This is insane. This is completely...
The alcoholic patient did have 10 pills of Librium mysteriously gone out of 20 when he didn't even have one. If he had taken those pills and alcohol combined, he would have been in respiratory depression, but he was only intoxicated, so that seems suspicious.
I need you to open your locker.
Yeah, right.
Open your locker.
You're gonna regret...
Open your locker or I will have security smash it open.
I guess those are the 10 pills of the alcoholic patient that went missing. Dr. Langdon is in trouble. He's most likely gonna get suspended at least.
Is the imprint code on these pills gonna match Louis' Librium? Go home, Frank.
I think this is equally painful for the mentor to be aware of the bad deeds of his favorite resident. Dr. Robbie is disappointed in him, big time.
No, it's not like you think. You remember whenever I helped my parents move, I was too cheap to pay for movers. I hurt my back. I told you that. You teased me about it. Remember? Well, our own Dr. Hagen prescribed me some pain meds and muscle relaxants. I was just weaning myself off. It was just for maintenance. I'm done.
I guess he's trying to explain that it's not a case of abuse and that he actually used it for maintenance and was on the tapering regimen.
Robbie, come on. You know me, Robbie. You know me, man. I'm sorry. I was trying to...
What, steal pills?
No, it's not like you don't understand.
I don't understand.
It's not like you think. I'm not high. I'm not high.
He was probably abusing it for the sedative and euphoric effects. The euphoric high when taken in large doses or mixed with alcohol or opioids to increase the CNS depressant effects. This is just sad to see.
You've seen what I do, Robbie. Could a drug addict do what I do?
Apparently. I just at him. You're done. Leave now or I will have Ahmad escort you out.
Robbie, please.
You are done.
What?
Does this mean Dr. Langdon has been fired from the residency in his third and final year? That must be absolutely heart-wrenching for him. Dr. Robbie is one resident short now. It would be even tougher to work for him further down. Thanks for watching. See you in the next one.